Good morning, EGP learners. It's Dr. Andy Foster here with Dr. Gandhi Hussain for your weekly or bi-week or fortnightly EGP learning update. So interesting times in general practice at the moment. Certainly the hot issue that we've all been talking around in Nottinghamshire this week is the COVID-19 vaccination and the DES, or now enhanced service, released by NHS England to describe how GPs may play their role in this important event. So just to say, if we're going to be talking about it, and some of what we say might be a little bit controversial, particularly to lay people who might be watching or people who aren't more deeply involved and invested in general practice. So I think it's important to say that the COVID-19 vaccination programme is vitally important. This will be the biggest mass vaccination program over a short period of time in the history of the country, in the history of the world. It is absolutely unprecedented, and it is important that general practice plays its part in this enormous effort to deliver the vaccine. It is important that what we do is safe. It's important that what we do is practical, and that what we do is achievable, and that general practice balances the delivery of this vaccine with the other important and vital work that general practice does in terms of delivering day-to-day care for people, our role in cancer screening programs, picking up acute, long-term, and important and significant illness. So it's really important that what we do and what we sign up for works and delivers and enables us to continue doing the other important work that we do. So yes, this has met with some controversy. That's perhaps a lot of what we'll talk about today, but we just have to be clear from EGP Learning that it is vitally important that general practice plays its part in this essential mass vaccination program. So now that we've got that out of the way and just been clear about where we are positioning our discussion today, let's move on and move forwards. So so last week we had what was our most popular episode ever, really, fastest to 1,000, fastest past a number of landmarks, where we focused on the COVID-19 vaccination enhanced service, or the anticipated enhanced service at that stage. A lot more details emerged throughout the week, a lot more discussion has taken place, and we're going to be reflecting on a lot of that now. But just going to say hello to Gandhi. Gandhi, hi there, how are you over in your part of Nottingham?
Yeah, doing okay. Sorry, I've been slightly distracted because we're just trying to coordinate some of our guests as well. And just remembering that this episode is live, everybody, so you can join in. And thank you for saying hi already. I think people are doing so. Yep. Hi, Ishani. Thank you for joining us again. I know you joined us last week as well. And just to point out, if you do want to join us, we are going to give people the opportunity to try and join us later on screen as well as we cover this episode. Definitely let us know where you're from and how you are planning on tackling the COVID vaccination DES in your area. We'd love to hear your examples. We're going to be talking a little bit later on about the Nottingham plan. We've got some guests coming on to share that with us. And yeah, hi to all the people that are watching us on the replay, because thank you for watching us on the replay. We've been doing some really interesting stuff with this lately. So we are trying new things today. So we'll see how it goes, won't we, Andy?
We will, yeah. So Gandhi's currently trying to coordinate with Tracy Madge, who is a local healthcare leader in Nottinghamshire and has been leading up the locally developed Nottingham COVID-19 max vaccination program. How are you getting on there? Have you got Tracy sorted and lined up, Gandhi?
We've got Tracy queued up, and we're going to bring her on in a short while. I know we just wanted to cover some of the updates that have happened since then. Just because, so everyone's got a good standing of what the ask is, and particularly why we're thinking what is hopefully happening in Nottingham will be a really good example to share with people. Is it worth it we go through that now, Andy?
Yeah, so Gandhi, obviously a lot's happened this week. I was in another meeting at the time of the NHS England webinar on Thursday, so I didn't get to see it. I've not been able to watch the replay, but I know you were watching and making notes at the time. So can you update me and perhaps some of the other people who didn't see that on the developments that were discussed there?
Sure thing. So just if you do want to update, I know Andy's going to put this on screen. So this is obviously what we're talking about today. If you do want to get an update in terms of the actual specifications of the DES, or we'll come to that part of it in a second, feel free to check out our episode that we did on Wednesday that basically is me going through the actual letters that we've had so far in terms of the DES letter, in terms of the Annex A, which is the actual specifications of the vaccination program, Annex B, which speaks specifically about the site specifications that you need to look at. And then there's the fourth letter, which is the extra funding to general practice to support the efforts to deliver the vaccine outside of the actual vaccination part. So the fabled, the log talked about 150 million pounds, which I guess for Nottinghamshire that equates to about 2.7 million that's being pumped in to support general practice and stuff. But since then, there have been, that video talks about those letters. Since then, there have been some key changes, and we're just briefly going to summarize what those adjustments are. And this is clearly because of the fact that this is a rapidly developing and adjusting situation. So first and foremost, it's not a DES. That's the first thing we've figured out. So just for those that aren't aware of what the contractual elements and stuff are, enhanced services are stuff that's basically in addition to the GP contract that many practices are delivering to general practice. They can take the form of various different types. We've got direct enhanced services, which is, if, for example, what the primary care network element of work that we're doing is. You can have local enhanced services, which are, as it sounds, locally derived through the CCGs or other areas. There is a NES, and I always get a bit confused in terms of where that sits in comparison to DESs. I think it's only been used once, which was to do with a few years back. But what we have found out is that what is being offered through the COVID vaccination is, I think it's been called the NHSE Enhanced Service. It's using Section 7 something or other in the health legislation elements. But basically, it's like a DES, but it's not specifically a DES, and that's to allow for rapid changes that may need to happen in order to facilitate an effective vaccination delivery, because obviously we are dealing with an exceptional situation. Does that make sense, Andy?
A little bit. So I guess what I'm hearing there, Gandhi, is that they can change it after you've signed up for it. Is that essentially what that means?
Yes. Now, there is still, it's not just that they can change, NHS England can change it arbitrarily. There has to be an agreement with the GPC in terms of those changes. But what it does mean, it doesn't have to go through the same regulatory periods in terms of the change that would have to happen to a DES, because they are contractually written out in legislation and stuff. It is slightly an interesting issue because obviously when this went to the GPC, from my understanding, a lot of the GPC representatives were under the impression this was a DES. So they voted on it on the basis that this was a DES, not a different structure. Does that impact how the vote would have gone last week? Don't know. But obviously, it's a plus and minus, isn't it? I can understand the need for a different mechanism because of the change. And we're going to talk about a couple of those in a second anyway, that's already happened. And would they have been able to happen if this wasn't a different contracting arrangement? I don't know. That's for people far higher than us to figure out. But at the same time, there is this element of, well, we're in new territory, and I can definitely understand some people are concerned that does this mean they could have a massive change and we don't even recognize the implications of that? Maybe. I don't know.
Yeah,
so, yeah,
it's a fast-moving area, isn't it? I mean, I can understand why NHS England might want the flexibility to change things for practical reasons afterwards, but then you can also understand why some people who might be signing up to this contract might have reservations about that. So I suppose there's two sides to the story.
Yeah, absolutely. Second one, and I know this has been the big one that many people have been worried about, is this whole element of it being 7 days a week, 8 till 8 o'clock. Why does it have to be that? So we had a clarification on this, and the key clarification is the fact that the reason why that's written in the enhanced service, and we're going to be calling it enhanced service from now onwards, just so we don't get confused about the nomenclature and stuff, is simply that there are, as many people are aware, there are issues in the cold chain in terms of how the vaccines are stored. And basically, when places get their delivery, they have 5 days to use that store. Now, clearly, if you were to get delivery on a Thursday and you were contractually only able to deliver this Monday to Friday, you lose 2 days in terms of delivering the vaccine. And that's massively going to impact your ability to vaccinate the population and not waste the vaccine. And clearly, we have to be cautious. We cannot be wasting this vaccine. It's really precious. Getting doses is a challenge. We know we're not going to have enough doses to vaccinate everybody in the near future. It's going to take time to develop that. So one of the things they made quite clear on the webinar is the reason why it states 7 days a week, 8 till 8, is just so that it allows practices to have that mechanism to therefore vaccinate people over the timeframes when they get the vaccine. That doesn't mean you have to deliver 7 days a week, 8 till 8 service. Okay. It just gives you the viability to do it. And I also kind of wonder if it's also in an effort to try and support you using things like extended access and extended hours services as well, because one of the things they did clarify as well is you can use those services to deliver the vaccine. That's fine. So it helps, I guess, with the contractual elements and stuff.
And so, yeah, I think that clarification is really, really helpful, actually. And so I remember last week we were looking at headlines from The Sun saying that GP surgeries would be open Christmas Day, Boxing Day. So I suppose what this is saying is that really it's according to need and for to ensure that vaccine isn't wasted. So I'm assuming, Gandhi, that with good planning, we may be in a position where GP surgeries don't feel that they are being asked to definitely be open on those bank holidays. Would you agree with that?
Yeah, so absolutely. One of the things they commented on is that there is not a plan that practices should be open on Christmas Day and Boxing Day, like what happened in the April bank and May bank holidays. However, what they have said is clearly if you get your delivery, and unfortunately, as part of the delivery cycles, we don't know, but if you get your delivery the day before Christmas Day, if you get it on Christmas Eve, losing 2 days to deliver your vaccine may unfortunately mean that you have to deliver a vaccination program over those bank holidays in order to ensure that you get appropriate use of your vaccine. Now, hopefully, places won't be getting deliveries on Christmas Eve. That's not
Yeah,
going to be a great thing to happen.
Candy, I'm not sure that my parents are going to go for their vaccination on Christmas Day. I mean, to be quite honest, I don't know how many vaccines you would get through, on Christmas Day, Boxing Day, anyway. Just in terms of uptake, I think that there's a potential issue. But just wanted to highlight that.
True. I mean, there was a comment that those not celebrating Christmas traditionally celebrating Christmas may be interested in having their vaccines done. Okay,
True.
I can kind of get that, but at the same time, I know general practice would love a break, to be honest.
Yeah.
But we will see. I think that's the reason why that was included in. The other absolute massive change, and I suspect this is one of the reasons why having it as not a DES is useful. One of the clarifications that has come, and it was definitely a concern for many people, was the 15-minute wait and how you coordinate that with social distancing in terms of monitoring patients had to happen. We've now had further clarification that there is not a need for a 15-minute wait after vaccination unless the person is driving afterwards, and that's for absolute safety to make sure that there's no concerns and issues and stuff. So that is a significant change, I think, because that was a logistical challenge for many people to deal with. So the fact that patients, once they've had their vaccinations, do not have to hang around for 15 minutes to be observed unless they are driving.
I think that's really good because that's got implications for the sort of sites people would be using, because the sort of throughput that we were talking about to get through those vaccines, 1,000 vaccinations a week, was implying quite a large socially distanced waiting area as a holding pen for people after their vaccines. So I think it's really helpful from an estate's perspective and a potential venue perspective that has changed.
Sure. Next up, so consent process. Again, this is one that's causing many people concerns in terms of how you can make the consent flow, because for many people, myself included, that's seen as one of the big rate limiting steps that you have to go through to make sure people can consent and stuff. But what we have been told is a lot of that consent process we will have information from Public Health England to help support us with the consent process and potentially even a video. That would be the awesome part. Imagine being able to send patients a video with all your information beforehand. I know we've got some examples locally in Nottingham of some of the stuff that we're trying to do to help that process. And I'm sure hopefully Trace will be able to talk about some of that. But that's going to be the rate limiting step, I think, for many people is, an appropriate informed consent process and having that additional information, and more importantly, standardized information centrally, I think is going to make the process a lot easier. So the confirmation we're going to have something is nice. So I think that's going to be useful. And then next up, so we've got some information on the characteristics of the vaccine coming up. The last additional point that I got from the vaccine and stuff is simply put that indemnity is going to be covered. So just so that people are aware, indemnity is covered from a clinician point of view, but also it looks like that indemnity is going to be expanded to include volunteers as well. So that's the CNSGPs or an NHS resolutions that many people may know about. That's going to also include volunteers. And that's really helpful because obviously there was potentially, I guess for many places, they are going to need to use volunteers, a concern that, if they are supporting and there's an issue, then how does that play for the volunteers in terms of indemnity and liability and all that kind of stuff? So, good. There may be more changes. Chances are there's going to be, let's be honest, it's a rapidly evolving situation, but that's the main stuff I took from the webinar. I'm more than happy if anybody else on the chat or watching afterwards wants to comment on additional stuff that we've missed in terms of the DES specifically. I know there's other things that were covered. But that's the big stuff that I took from it, and hopefully that's a nice update in conjunction with the video we've done before.
Yeah,
The only
that's really helpful, Gandhi. Yeah, thanks very much on behalf of the viewers.
Yeah.
Gandhi, I know there was some information about vaccine characteristics, which we'd summarise in a little table, and I think they went into some detail in that at the webinar. Do you want to just walk us through, because it does have implications for the delivery, and in particular, do they know which vaccine or in what proportions of each vaccine we're going to get?
No, so I guess we've had one question already come in on the chat, and hi to Winnie Josie in terms of her comments. So why deliver on Xmas Eve? I think that's because we just don't know the supply of the vaccines that's coming through. Obviously, they're trying to produce significant sums and information and stuff. So we just don't know when they're coming. We know we've got some coming, but we don't know when. We don't know how. As many people can understand, this is a massive logistical challenge. It should not be underestimated, the significance of how difficult this process is going to be. And we're probably going to talk about some of those challenges later on between us. But in terms of the vaccines, so we've had a little bit more information about what they are. So they've got code names. So Courageous and Talent. Courageous is the Pfizer one that many people probably have heard about in the papers at the earlier part of this week, the one with the 90% efficacy and stuff in terms of vaccinating people. And there's basically a comparison of what I managed to pick up from the presentation in terms of the differences between the two vaccines. Again, we don't know which vaccine at this point practice is going to have, in which numbers, whether sites are going to have different vaccines. They're not approved yet, as I think one of our Vij Good has mentioned. They're currently not approved, but this is the plan as such. But yeah, effectively, that's the main comparison. Interesting to know about the Pfizer one, that it is a new type of vaccine. So unlike the Talent one, which is a standard kind of adenovector, so denatured, so it's using a vector to create a virus that then your body has a response to. The Courageous one is using a new method whereby they're massively replicating the RNA of the virus, so then that hopefully does create an immune response and stuff. So it is a new type of virus and will need MRHA approval. But as you can see, there's the information there. Just really briefly to summarize it, they both need to be stored in deep storage at sub 0 degrees C. So one's at minus 15 degrees C, one's at minus 80 degrees C, which practices won't be doing. When they arrive at practices or networks or whatever, they have to be stored at 2 to 8 degrees. And we assume they're both for 5 days. I must admit, for the Talent one, I can't quite figure out if it is the same process or same time frame. At room temperature, they're only available for a really short period of time, 2 to 4 hours, depending on which vaccine. You get different numbers of doses per vial, but they come in pre-made vials. The Courageous one then needs to be diluted with saline in order for it to be used. So there is an administrative process that happens there. The second dose, so both of these vaccines require you to have a second dose before you're fully immunized. The Courageous one is 21 days later. The Talent one is 28 days later, and they must be given 7 days apart from the existing seasonal flu vaccination. And really important part to note is that in terms of sequence of the vaccines, what's being recommended is that you either have the seasonal vaccination either before you have the COVID vaccination by 7 days or after the COVID vaccination by 7 days, not in between. So you can't go COVID vaccination, seasonal vaccination, COVID vaccination. That should not happen, because that's just going to really complicate the process. So yeah, that's the best information I could take from the vaccines update. I hope that's all right, Andy.
Yeah, that's great. I've got a few questions actually. So the 975 vials, so that's not on this chart.
They are coming in
for that.
975. Yeah. So the reason I haven't put that on the chart is because it's the same for both of them.
Okay.
Locations will get deliveries of batches of 975 vaccines. Now, I'm assuming if it's the Talent, it'll be slightly different, because as you've seen, they come in dose vials of 8 to 10, so it doesn't quite match up. But the aim is that you get doses of that. So, for example, the Courageous one, you will get, what is it going to be? It's going to be...
They said 1,000 dose vial, didn't they?
Yeah, it's going to be about 180 vials of 5 vial doses or something like that.
Okay. So they are. So it's already divided into 5 vial doses, because that was part of the process. I was struggling to get my head around in terms of how locally you take what sounded like a huge bottle of vaccine and decanter it out. But okay, that makes more sense. But you wonder why they still need to deliver in 1,000 batch sizes if it's already divided? I'm just
So
trying to get my
absolutely.
head around that.
Yeah, this is one of the things that's causing a lot of frustrations, I think, for many areas as they're trying to work out logistics. If it's coming in separate vials, why is it that those doses cannot be split site? And the simple advice that we've been told is that that's what the drug company is saying in terms of to have confirmed liability with the dosing and the administration. So, in short, I think you could split them. However, the liability and responsibility of doing that is against the current, what looks like to be the MRHA and the drug company's advice. So if something untoward was to happen, i.e., an adverse reaction, etc., then whoever decided to split those doses will be completely and utterly liable and responsible for the implications of that. And
Okay.
that's how it's planning. So the NHSE were very clear, so Nikki Kanani and Ed Waller were very clear about this. They're not making this rule. This is the rule they've been told they have to stick by. And whilst it may seem illogical and more complicated, it is the rules that we're at the present having to stick by in order to make sure that the liabilities and everything are covered to make sure we're giving a safe vaccination. Now, again, that may change, might do, but that's what we have. So trust me, I know locally we've had a lot of discussion about this as well. It's probably the main sticking point in terms of the vaccination elements and stuff as well. But if if you split the dosing, if you split the supplies, you are liable for that. How that quite works with going out to deliver at home, I know, but yeah.
Well, I have to do
But
it within 2 hours, I suppose. 2 hours
yeah,
travel time. Yeah, okay, right. I can. That's helped me get my head around it a little bit, Gandhi. It's still a bit confusing, but okay. The
cool.
drugs company say no, so that's
The-
that's. I think it'll be
the-
easier when we start to see what it actually looks like.
yeah,
It might be obvious from how it's kind of packaged or something.
yeah.
But yeah. So I get that. That's fine.
Okay.
Yeah. I think
Before we move on, I can answer a
oh,
couple of questions we've had in the chat, if that's all right,
go for
Andy.
it.
Really rapidly, and then we're going to crack on to the next part, which is bring on our guest who's been waiting really patiently. Will there be in control in terms of ordering too much in terms of capacity to vaccinate? So there's a question by Paul. Really sorry, I'm not sure if I can say this right. With Zora. In terms of designations of site, from what we understand, again, we're not the people making this decision. That you will have to prove in some way, shape, or form that you can cope with those amounts. And there is a responsibility in terms of making sure there's minimal wastage that comes into those plans. So that's why many places are being asked to submit their plans now in preparation for all of this. So that shouldn't logically happen. I've heard that some people are having delivery at different sites to vaccination, although very close. Is this possible? I think we've covered that. The answer is once you've nominated your site, that's where the vaccine goes. You should not be splitting it. That's what we understand to be the implications of things so far. I thought courageous was minus 75 degrees plus or minus 15 degrees, not 15 degrees. I've copied this over from the slides that we've seen from the webinar. So apologies, Hillary, if you know something different to us, more than happy to accept that. But as I said, I've just copied this over from the webinar that we've seen. JD's asked about, do they both require dilution? No. Courageous, as far as we're aware, is the only one that requires dilution, whereas Talent is already made and doesn't require further dilution, but does require you to draw it up. So it won't come in pre-made syringes. You just have to draw it up. What have we got next? Let's have a look at. So Vid's asking about, is it a phase 4 trial or somewhat unethical? I have no idea, Vid, if I'm being honest. Not quite clear on this one.
It's an interesting point though about uptake, isn't it? Because I
Yeah.
know anecdotally, people have been telling me that they've been having conversations with people, and and people aren't necessarily as keen as you might think they should be about the vaccine. So, interesting. Yeah.
So Paul's asking, it doesn't make sense we can deliver at home and care home, but not at practice. We can maintain the cold chain. Do you think this will change? Maybe, don't know. But this is the current advice as of the 14th of November. Obviously, as I mentioned, this stuff has changed within the 5 days since it's come out twice already. So yeah, possibly may change. But at the moment, we're telling you what we know as of this moment in time. Knowing our luck, as soon as we finish this, will change.
It's also experimental.
I know that there are meetings happening right now as we're delivering this webinar, so yeah, potentially it may change. And Rob's mentioned it looks like the logistics of the second dose require more supply stress. Or if you run out when the patients expect the second dose? Yeah, we're going to come on to logistics a bit later on, aren't we, Andy, in terms of discussion? But hopefully we can tackle some of more of your deeper questions shortly. So at this point, is it all right if we move on, Andy? Yeah.
Yeah, sure. Let's. Are we moving on to our local plan and Tracy?
Yeah. So at this point, I'd like to introduce everybody to Tracy Madge. So hopefully you can all see her. How are we doing, Tracy?
Yeah, good, thank you. I think you're going to have to share the screen for me.
That's not a problem. So we'll do that in a second. But we just wanted to say hi. So for those that don't know, Tracy Madge is our local leader who's been coordinating, I believe, for the past 4 months, the process of trying to figure out COVID vaccination for the Nottinghamshire area, and has done some really amazing work. And one of the reasons we wanted to bring Tracy on was to share the work that she and her team have been doing. And I know it's very much been a team effort, and very much an integrated approach. We've had both me and Andy, because of our positions as both clinical directors and mine as an LMC representative, has seen these presentations a few times, and effectively we wanted to share, I guess, what we're doing locally to give some ideas and options. And then after Tracy's kind of talked through her process, we're going to then move on to, I guess, a discussion between us and everybody else who wants to join us in terms of what this may mean for your local area and the DES and everything else. But yeah, Tracy asked us to share the slides, so I'm going to bring those on right now. And this is, I guess, the big one, isn't it, Tracy?
Yeah, I mean, this tries to tell you on a one page what the we're calling our local resilience forum. So we are approaching this as it is a public health emergency. So we are really trying to look at it as a system rather than individual components. So we're trying to work in a very cohesive way. And the way we have developed our plan in Nottinghamshire, it's been since late August when we were first sort of hearing that the COVID vaccine programme may be a reality. So we've probably been in the planning stage for about 8 weeks. So it is complex, but I keep reminding people it's a vaccine we're delivering. So it's not surgery, it's not brain surgery, it is a vaccine that we're delivering with complexities within that. So from a system point of view, we're describing it as a clinical area and a clinical directorate. And the reason that we are doing that is because a lot of the people who are going to be working in this service will be our lowest paid clinical clinicians. So we can now have band 4 vaccinators who can come from the fire service, from healthcare assistants who are now legally able to be trained to be a vaccinator. So we have to talk in a way that they understand, and a lot of the staff at that level understand the parameters of what a clinical ward is, because a lot of them will come from hospitals as well. So we've described it as a directorate, and we're setting up a new directorate in Nottinghamshire, and our directorate will deliver the COVID vaccine across a number of wards or clinics, as we're calling them. So we have worked this up with our LMC, as Gandhi says. We've been working with the LMC since we heard about the vaccination programme, and also GP colleagues, to see how we might provide a plan that makes sense clinically. And because I'm a nurse, I'm absolutely key to me is the quality. So what's driven our programme is keeping not only our patients safe, but our staff safe. So this whole model is built from a principle of safety and quality rather than a financial thing, although the finances are important. So like any good directorate in a hospital, if we were starting one up, we would need the infrastructure. So you'll see to the left, so from October, we have a range of what we're calling enablers. So how we're going to pay for it, how the IT is going to work, how the contracting is going to work, how we're going to communicate, how we're going to staff it. So for this model, we're probably looking at around 1,600 staff. Regardless of whether it's an ES or a local plan, that's the sort of number of staff to deliver the vaccines as being modelled through. We've got a state, so any site that we set up has got to be CQC regulated, it's got to be able to receive the vaccine, it's got to have areas where that vaccine can be drawn up safely, and it's got to have areas where people can be socially distanced as they come in. So there's quite a lot of logistics around the estates that we're working through. The data is how many vaccines are we going to get, when are we going to get them, and how many vaccines are we supposed to be giving per hour, and therefore that leads us to a staffing model. So how many people do you need on at any one time? We have a primary care lead, which is a clinical lead from our localities, and a locality director who will be working out the primary care ask of this, and what the GP role is in helping this whole system deliver what is unprecedented. It is unprecedented. It is the biggest thing, I think, in our lifetime that we'll ever do, and hopefully our children's lifetimes. We also have somebody in charge, so we're working as a system. We divvy up all of the responsibilities across the system. So our mental health trust is going to be doing the overall governance. Are we good? Are we safe? Have we got all the reporting in correctly? Are the finances accounted for properly? We've also got Nottingham University Hospitals who are acting as our quality committee. So if you think of the thousands and thousands of patients going through the service points, there will be incidents, there will be accidents, and there will be complaints. Hopefully no serious incidents, but we have a committee, so we will send all of our procedures and processes through that, and we will have directorate leads who will manage all of those complaints and incidents on behalf of the system. So any patient who's complaining, they'll go straight through to that person. They will manage that, and they will do a report to the Clinical Governance Committee at NUH. We've already set up a bank, so regardless of whether we do the ES or the plan, we've currently had over 2,200 staff register for that bank, and over 1,500 of those are health staff, and they range from community pharmacists, nurses from all avenues, primary care and wherever. And the first thing that they did about 4 weeks ago was complete a survey to say, when can you work? What can you do? What's your current band? And we're now actually putting out the job descriptions across the NHS jobs for our bands 4, 5 and 6. And we will have our job descriptions out for GPs on Monday, which explains the medical role, which I can talk a bit more about shortly. So they're really strong enabling work streams which keep us safe. So as a clinician myself, I want to feel safe. I want to know there are people around me that I can get support from as I'm delivering quite a complex, huge logistical program. So we feel we've got the right infrastructure. And then we have our wards. So for purposes of simplicity, wards 1, 2 and 3. Wards 1 and 2 are our vaccine supply. So they need to be staffed. They need the right clinical governance. So all of the enablers again. And as I won't talk about the vaccine characteristics because that's been done. But as you can see, there's still a lot of unknowns that we don't know. The end-to-end user, can you, and I know people are saying, why can't it go to practices? We're asking exactly the same questions. So lots more to flush out, I think, over the next couple of weeks around the vaccine and where it can go. But it is an end-to-end user that is required. The ward 3 is the consumables. So how do you get your PPE? How do you get your non-clinical supplies? How do you get your sharp bins? So anything that's to do with the ward. So how do you get your tables, your chair, all sorts. The whole non-clinical infrastructure that is required to enable people to do their job properly. So we have our chief pharmacist from the CCG, Mindy Bassi, who's leading that. We've now got a lead for the consumables, who's Lindsay Sutherland, and they are working together to design the SOPs and adopt the national SOPs that will enable us to understand how that vaccine and non-clinical supply comes through. So we'll be doing really simple pages of A4 that will say this is how it comes through, adopting the national system. So once all that's in order, and we need that, so we need a vaccine supply in order to mobilise the service. If we haven't got that, we can't do it. So again, that's going to be really close to the wire. It's going to be end of November before we know the vaccine in detail and the numbers. But we do know it's going to be tens of thousands of vaccines that are required over a very short period of time. We have our IT director of HIS who is working with a local GP to design the local booking and call and recall system. There will be a national system. I think what's really important for GPs to remember, there will be patient choice. So of the 975 vaccines that are in the ES, if your patients choose to go anywhere, they can go anywhere. And I think there's a view you can go anywhere nationally. So wherever you want to have your vaccine. And I often use my mother-in-law, who would go and have a haircut in Nottingham, but lives in Grantham. So she'd probably have a vaccine while she was having her hair done. So lots of patient choice things to be factored in. So our first ward to come online is care homes. So they're in the JCVI cohorts and how we phase them. So we will receive vaccines to populate our care homes. For Nottinghamshire, we have 368 care homes, and we have 1,061 extra care facilities. So there's where our most vulnerable population lie. For the care homes alone, that's a 15,000 population. It's 12,500 residents, and it's 3,500 staff. So that's huge. We have a plan, so we are 90% sure that we will be ready to go on the 9th of December. We've recruited 100 staff to the rota, and they will be dispatched in ascending order of nursing homes first, because they have the correct clinical environment for the vaccine that has to be reconstituted. They have the right fridges, for example. So they will go out on a rota and start to vaccinate all of our care homes, and they will probably use the bulk of the vaccine supply in the first week. Alongside that, staff vaccinations, we will also get a supply of staff vaccinations that will go to the acute trusts in our area, and we will start that vaccination programme of those two. So the two of those go hand in glove. So the leads for that are working out how many vaccines are required for each of those areas, so that we are not robbing Peter to pay Paul. The important thing about the care home community being vaccinated is that we've got lots of outbreaks in those care homes. The sooner we can get them vaccinated and safe, the sooner they open, and the sooner we have discharge pathways that open up again to all of our homes. So it is a real significant priority to support the winter pressures that we're under, and to support our acute trusts that are extremely busy and need that flow out. There will be a way of understanding. So all of these areas will be either recording onto NIMS if you're staff, which goes to the GP record, and we will be going directly into the GP record to record all of those. So we already have access to that in our system. So the care homes team that are doing this will know how many patients are ill and not able to have the vaccine. So they'll be able to plug in an appointment for when they can go back and complete that vaccination. We're aiming for 100% offer across those care homes, and we in Nottingham would like to have 100% uptake in those areas. We do know the sort of target is around 75%, so we'll be working to understand when can those homes open if they have a 75% target achieved. So that's from the 9th.
Tracy, and with that, so we've had a question about our primary care looking after the care homes. I guess it's important to recognise that in Nottingham, we're fortunate that most areas have a care home service, but that's going to be in combination with general practice supporting the vaccination of the care home residents. That's my understanding of it. Is that correct?
That's absolutely, yeah. And basically the staff supply that we've got, anybody can be part of that. So the GPs can be part of that. Their practice staff can be part of it. So the current plan gives GPs the choice. So just to say, in Nottinghamshire, we've had a care home teams that have been doing the flu vaccination on behalf of GPs. So out of the 368, they've done over 120 care homes on behalf of the GP. So the GP still receives the flu payment, but we've supported them to rapidly do the flu vaccination programme. So our care home residents are ready to have their COVID vaccine, and they are already starting to understand the consent, because we are assuming it's implied like flu, but we know that IMCA will apply for a lot of our care home residents. So we are trying to mobilise the consent issue next week. So that's all in place. So we're ready to go. But our team includes GPs. It's a real flattened hierarchy. It's GPs, practice nurses, practice staff. We're all part of the rota, and currently can choose to be part of the rota rather than having to do it. And obviously the addition of the enhanced service means how do we work with that and the implications for GPs. But that's what we're doing next week. I'll pause. Want me to pause?
No, I'll give you a few more minutes. I'm aware I gave you the absolute mammoth task of getting through this presentation as quickly as possible, because I know your presentations have actually lasted 40 minutes. And I'm going to
go through this one now. So as of this, from January, but if we can get more supply, we'll start to do the roving and the housebound. That's primary care led. It's all around GP supporting us with that and their staff. And then we'll open up our large mass sites. Again, GPs, we need GPs for cover there because of the volume. We have to have a medical director, a GP on site for 12 hours a day. We've already had 63 GPs put their hand up for that, and we've had 100 more express an interest for that role. And then from mid-January, we will start to onboard all our practice-based clinics. So that was our plan before the ES, and we're now looking at how the ES fits into that and make sure that we work as a team, so we keep the complexity as easy and as simple as possible. So that's where we are. I know these slides will go out, Gandhi, but the next two slides really just try and help GPs to understand what the pros and cons are, if you like. So I've done a PESTLE analysis on what the local plan is versus what the, so this is the LRF delivery model. I'm not going to go into all of this detail because I know Gandhi will send it out, but we know there's a lot of political issues for us to drive this forward. We were told, to set up mass sites, and we got the enhanced service specification on the 9th of November, and we were told in September to go, and we have to mobilise. So we have to keep going with the local plan because we have to start vaccinating on the 9th, and I think we'd all agree that that is important that we get going. So they're the sort of strengths and weaknesses, and unless people want to pick any of those out, what it does do, because we've got our 8 sites across the patch that have been agreed by the system, we're ready to mobilise those 8 sites, and we need all of those 8 sites as well as general practice, enhanced service. We need it all. So that's the local plan. I'll skip to the next plan. The next.
I think unfortunately we don't have that slide loaded up, Tracy. We're from a different slide deck, but so apologies about that, Tracy.
I think what we will do is after we finish the stream, we'll stick up the links to the stuff that Tracy has sent us, so everyone else will be able to have a look at those in more detail. So don't worry if you've not had a chance. Yeah, we will stick them up. It will be in the show notes for the YouTube one. So if you are watching us on Facebook, you will need to click on the YouTube link to have a look at it in the show notes there. But we'll stick a link. Give us about an hour or so to do it after the stream, though. And yeah, we will have it there for you. Thank you, Tracy. That's been really useful. I know we've had loads of questions already about this. And yeah, I guess we've even had comments from some of our local GPs. So we've got Jonathan, who's here, who's already commented as a Nottingham GP. I must say it's an excellent piece of work. Makes complete sense to use it and deliver such a huge, important piece of work. We've had other people talking about how jealous they are. How often do we hear that? I'm jealous that this is an amazing blueprint, and clearly other places have different timeframes that we're looking at. I know we've had questions about some of the other stuff that's come through with this. So one of the ones I wanted to bring up was this one by Shani. What can non-clinical volunteers do, and are they able to physically vaccinate or be support staff? I know you've got lots of information on this, Tracy.
Yeah. So for the clinic, for the actual physical act of giving the vaccine, the JCVI have published a guidance now that as long as you're a healthcare assistant at MVQ level 3 and above, so you've got to have your MVQ and you've got to be working in a sort of health environment or social care environment, you can now go online, do your flu vac training, and then there'll be a 3-hour COVID module we're expecting once the vaccine characteristics are in place. So all of our bands 4, 5 and 6 that were on board, they call it onboarding, it's a really unpleasant word, but HR will put them onto the bank, so they'll all be indemnified through CNST, and they'll all have their training paid. So once they have completed that training, we'll bolt on the COVID module and they'll be good to go. We have got volunteers, so we're hoping to have volunteer interpreters at all of the mass sites. So people's languages at first language isn't English, they'll be there. And we'll also have people helping us with the deaf and the blind community. And we will have St. John's Ambulance on site to support any sort of first aid issues that we have. We're in discussions with the police to provide a patrol where they can, and we will have security on site for all hours to protect those sites 24 hours a day. So that's where we are locally. We've actually thought about all of that like we would in a directorate in a hospital. You know, you would expect the same. So we expect the same for this service. It's no different.
Mm-hmm. And I guess that creates clearly a challenge. I know Christine's mentioned already some confusion about for HCAs is MVQ3 not equivalent, or that they needed different training and stuff. I don't know.
Yeah, the job descriptions are live on NHS Jobs. If people want to look at Sherwood Forest Hospitals are advertising the bands 4, 5 and 6. So it's MVQ level 3, yes. And we were told that the webinar, the COVID module, was up to 3 hours. I mean, obviously we won't know until the final vaccine characteristics are known, but I think we're saying it could be up to 3 hours, so people have factored that into their induction.
Sure. And I think, like you mentioned, a lot of the stuff isn't known. So Vinay's commenting about how would you go about the consent process next week in advance of knowing which vaccine will be used. I think some elements of how you do the consent are going to be universal. So the method of delivering the consent is going to be pretty much the same, we think. Obviously, the content may be slightly different, but obviously we can adjust that as we progress. But that doesn't mean you don't stop working towards this, because as Tracy's mentioned a couple of times and we've mentioned a few times, the timeframes for this are unbelievably short. To have this ready in 2.5 weeks' time to get rolling, we can't wait for certain things to happen, I think. And I know from my view, I'm pretty sure Andy will comment on his perspective, the fact that so much of this work has been going on in the background, so much of it has been so well planned and thought out, that we just felt that the best option for Nottingham patients was that we align ourselves as much as possible to this local plan. And I guess that brings me on to the key question that I guess a lot of people are talking about. The question as a PCN lead is how to support this rather than sign up to the ES, the enhanced service. And I think somebody else mentioned fairly similar about the finance and stuff. I've already lost the comment. Where are we? Anyway, yeah, here we are. Eloise talking about how can we explain the flow, practice delivery site and stuff. I guess that's the challenge. We don't know. But I know the view we've taken is that potentially signing up to the enhanced service in our local area, and I'll make this very, very clear, this is a Nottingham view only, because we've got all this stuff to support us, that actually signing up to the enhanced service may actually cause more challenges in delivering it rather than what's the work that's already gone on. So, there is that complexity of the fact that we are keen to make sure the vaccination happens to our local areas, and I know my view is very much that we are looking to support our local areas plans that Tracy has just shared there, and the best way of doing that is potentially not signing up to enhanced service, because it sounds like the pot of money is exactly the same whichever one we use.
At the end of the day, we have to deliver a vaccination program, and we have to do it at scale and pace. It's absolutely unprecedented. So the more we can be consistent and the less complexity, the more chances of success. So I think, we don't know how the funding will flow, but we know there is funding, because if they're funding an enhanced service, then the funding is there. So we just need to understand what the implications are for us as a system. And it's not clear, as you say, Gandhi.
Yeah. And that's not to say that the enhanced service doesn't work. I think it can work. My personal view is that general practice on its own, trying to vaccinate its entire population, is not going to work. It needs the support of the system. It needs the support of primary care, midwives, district nurses, all the logistical stuff that comes outside of that, the councils, or it has to be wider than the practice environment itself. And I think we're just really fortunate that we've had all this stuff help us really in Nottingham. Andy, go for it.
Yeah, no, I was going to say, so I think initially, and particularly after last week's podcast on Saturday, and when we were speculating about the content of the then DES, now ES, we were all quite worried, I think, locally about the implications for delivering the enhanced service that had just been sort of dropped out of thin air on us. And then we had the presentation from Tracy on the, I think the Tuesday or the Wednesday evening as clinical directors of primary care networks, and everybody was I think relieved and actually quite grateful that all of this excellent work had been being undertaken for several months prior, so that we had something really, really credible and sensible to go locally. Big respect that it's been treated as a major incident, and I really thought that was a great way to conceptualize it. The biggest mass vaccination exercise in the history of the country over a tight time scale, and I thought that was a really great way to conceptualize it, because that really helps mobilize all elements of the system in a combined effort. I thought it was great that we're seeing a whole system effort to deliver the vaccination, and that locally this isn't something that's just being I hate to use the word dumped, so that's not the right thing, but it's just being sprung on general practice alone to deliver. So I think that is really, really great, and I think it'll be more effective delivered in that way. And just as we've all been alluding to, I think what we're just all trying to get our head around is how the funding works and what the implications for signing up for or not signing up for the enhanced service is in terms of how we support this plan, which I think is universally accepted as the best way of doing it. So we're just getting our head around that over the next few days, running up to the 17th, I suppose. But yeah, thanks very much, Tracy. I think this is an absolutely excellent piece of work. But I think I'm speaking on behalf of everyone in Nottingham. Really, this looks great.
Can I just say, it's not just me behind this, or the LMC. You know, this is not Tracy's plan. It's a system plan. It's owned equally, and we could not have got to this plan without the clinical leaders in our patch supporting it and developing it with us. So it really is a co-designed plan with all of the partners, and all I've had the privilege to do is just pull it together into a slide deck to demonstrate the power of coming together as a system. So that there's many people that we need to thank, and we're all equal in this. We're a flattened hierarchy, and we've just got the best people with the best skills doing all the bits. So a massive thank you to the Nottinghamshire community and the clinical leaders in that community for helping us design what I think is a good plan. But the ES will be the ES, and whatever happens, we will work together, because we've got such a strong community of people wanting to make this work.
Absolutely. And I guess that's, showing off the Nottingham plan. So I'm going to give Tracy her excuse to leave if she wants to and stuff, because I completely appreciate she's sparing her valuable personal time to join us for this. So thank you, Tracy. We really do appreciate you being able to join us and share the plan and stuff. But yeah, definitely feel free to take back your Saturday now.
Good luck, everybody. I hope it goes okay. Thank you very much.
Thank you. But I guess the next part we wanted to cover, because obviously we've talked, I guess, about some of the ways that this can be achieved. Clearly, then there's the question of those practices are wanting to try and approach the DES, the enhanced service, and how that works and stuff. That there's clearly other things that need to be thought about and discussed. And we've already had some of the questions in the chat asking about some of this kind of stuff. I think the big one is obviously the IT elements of stuff. So Sakabash is mentioning, do we know anything about the IT infrastructure that will support this and what it will look like? No, at this point, it's being worked up. There is a national recall system being developed to support people being able to have their vaccinations done. And a lot of that, I think, will potentially feed into the mass vaccination sites that Tracy mentioned that have already been worked up. But in terms of locally, you have the capacity to do that yourself, or you can join the national recall system. Again, this was one of the things they did mention on the NHS webinar. This is in the DES, so it didn't really change. But just to be aware that if you join the national system, there are potentially some additional administrative requirements in order to do so. We don't know what they are, I'm afraid. I know last week we had Accurix come in and tell us about some of the stuff they're looking at trying to do. And obviously Accurix is a company that's really been supportive of general practice throughout the entire pandemic and things. And they've just literally this morning released their blog, which I can't quite grab a hold of just yet, but we will again stick it in the show notes and stuff. So unfortunately we can't. I don't know, Andy. Do you want to see if you can find it?
I'll try to find that in the background. You
continue. Whilst we're talking, so we're going to do the thing we shouldn't really do, which is not look at our screens and stuff. But I'm going to send Andy the link on WhatsApp, so hopefully he can put it on the screen. So then we can bring it up. But this is looking at some of the tech stuff that could potentially help with delivering it. Additionally, I know obviously the electronic health providers. So EMIS, System 1, that kind of stuff, are looking at ways that they can help general practice in terms of delivering and sorting out, vaccination processes and stuff. So I know I've been talking to System 1 about how they're doing this, and if they're able to work something up, bearing in mind there are loads of regulatory stuff going on, we will happily try and share that with you all as quickly as possible, and I'm sure everybody else will be doing so as well. But to say that, massively evolving and developing situation. So hopefully there will be some additional things that can be available to help practice with the IT, particularly the booking aspects of stuff. And even, simple things like sending consent. So one of the things I've been keen to try and make sure happens is a video for patients for their consent, because actually if you can send that to them beforehand, you improve the consent liability, as well as the information shared with patients. Having that obviously available in non-English speaking languages as well, really important. But then having a mechanism whereby a patient can reply back saying, I consent to this, and then that's stored automatically in the records, just like we do with photos and other kind of stuff. How awesome would that be? Because then that just makes the process so much easier and streamlined, because then you've got confirmed consent in terms of doing so. So the IT is a challenge, absolutely. In terms of setting this up in practices, I think one of the key things is how you go about it. So even though it's looking like our network is not going to sign up to the enhanced service, we are still working through having a local site to support the Nottingham plan and what that looks like and how that's going to function and stuff. I don't know if you've been doing the same, Andy, in terms of, 'cause I know,
We,
particularly
yeah, we have.
our buildings are being looked at potentially doing that.
Yeah, we're doing the same thing. It's such a rapidly evolving space. I mean, we were beginning to have conversation on Tuesday about local sites within the primary care network, where that was before Tracy's presentation on Wednesday, and the picture looks very different from then. So we were beginning to think about having conversations with local ICP, ICS partners in the council about the use of sort of sports hall type space to deliver, because our individual practices and their sort of size and the internal geography of them wasn't particularly lending itself to a max vaccination site, particularly with the prospect of having to have a holding pen for people to wait 15 minutes before leaving. So actually things have moved on so much since the conversations we were having on Tuesday. We're meeting again on Tuesday to have a further conversation, but we have to nominate our sites by Tuesday if we're signing up to the enhanced service, which we're not sure whether that's the best way to support Tracy and the local plan. So goodness me, such a fast moving space. Yeah, that probably doesn't answer your question, Gandhi, but it's hard to say.
It is hard to say. I think there's definitely going to be places where signing up to the enhanced service is going to work best for the local area. And as I said, we are fortunate that in the background, Nottingham has had so much additional work being done to support us. And I know within Nottingham as well that there's still many practices still considering that signing up to the enhanced service is going to be the best thing for their patients. And absolutely, if that works, that's great. I think there are logistical challenges with it, but to be honest, there's logistical challenges with any of this. Let's be honest, this is not.
Andy,
yeah.
Where were you looking for your site then? What's the specification of the place where your primary care network thinks it might put the site, if you don't mind me being so bold as to ask?
So a lot of the specifications is listed in Annex B, which, like I said, the links to those documents are in the show notes and stuff if people want to check them out. Effectively, you need a site large enough to house several, I would imagine, to have a throughput of at least about 100 people an hour. If you're trying to achieve some of the numbers you need to look at. So I know within our area, potentially, my practice building might be looked at because it's a combined lift building site with a lot of additional space. Don't know, we're looking at how that looks and shapes and stuff. There's clearly options there. I think Tracy mentioned one of the key things on this is that one of the things that the enhanced service documentation specifies that if you use an established primary care property, then you don't have to go through additional regulatory issues in terms of CQC and that kind of stuff. And that clearly makes the whole process a little bit easier. That may not be possible for everybody. But don't forget, you need to consider things like parking. You need to consider things like traffic. You need to consider things like open space. Okay, the post-op observation of 15 minutes is less of a concern. But if they're driving, that's still a concern, and parking and how they get there. I know some people talked about having drive-through vaccination sites. That massively increases the element of the 15-minute observation thing. So the only way they can get through this is through that. And I think, in terms of, the concept, what if somebody was to have an allergic reaction to the vaccine, how are you going to potentially try and do resus inside a car? Yeah,
I know. I'd had conversations with colleagues about drive-through setups and people who've had some experience before. And actually, whilst it sounds like a very simple thing to say, apparently the actual literal space required is much greater than you might initially think in terms of managing the cars. There are implications, I think, with local letting local police and traffic infrastructure know what is happening. Apparently it's a lot more complex than you might think. So just I'm sure people have done it. I'm sure it's doable. But it was a very interesting conversation I had. Gandhi, I was also going to ask about the CQC registration issue. This was something that came up in our primary care network meeting because we were previously the host for a CMC, or a sort of COVID assessment center, and there was a
management center.
Yeah, there was a clinical management center. That's it, and there was a lot of discussion about where, because that was in our building, the CQC registration was going to automatically fall on our practice, and many of my partners were not happy about that. And in the end, we had a workaround where there was a memorandum of understanding that the CQC liabilities were shared, or, we got somewhere different with that. I was just wondering, are you and your partners comfortable with the mass vaccination centre, or if that's the right term for your primary care network, and the CQC liabilities thereof landing with your practice if your building is used?
So no is a simple answer. I don't think we would be. And similar to yourself, we had concerns around that when the CMC element was being used. So my practice building was used as a CMC during the height of the pandemic. For clarity, my practice building is we are in a lift building, so we rent a portion of it. And then the rest of the building is owned by the council and sublet out. So actually, the rest of the building was used as the CMC, and we just made it quite clear that actually we're not responsible for that. If that was the case, then obviously that's a different question that needed to be asked. And actually, that was accepted, that it wasn't the practice's responsibility to house that. The building itself already had CQC approval. So therefore, actually, why did anything need to change? And it wasn't, the practice that was specifically liable. That's what it was then. We'll find out if it's different as we go through the process. Yeah, everything is evolving and changing. But I think the key thing with the CQC, so I think Stephanie's mentioned, how do you use a hall when CQC demand the site is registered? Yeah, that's a challenge. I know there is a process for registering non-clinical sites with CQC, and they have tried to make that process as easy as possible in light of the pandemic. But there is some guidance and stuff out there to support people if that's what they're considering doing, if that's the best option that's available to them. I think it's important to remember that definitely may be the case. We are talking about, I think, what potentially may work for us. Everywhere else is going to be different because of your local structures, local support, all that kind of stuff that's happening. And absolutely, I can definitely see how some places where the enhanced service is going to work potentially quite well for them based on how their current structures and stuff are evolving and things. I know we've got loads of questions that come up, Andy. So
yeah, we perhaps don't have the answers. I don't know, but sometimes just giving those questions airtime, is really helpful, isn't it?
Yeah. So I think that's the first thing we're going to say. We do not have all the answers. I'm really sorry if that, in terms of what we're going to try. But we had a couple. So Sophia Raja, are we allowed to vaccinate from a different site to where we store the vaccine? We answered this earlier. I'm afraid, as far as it stands currently, no. Where you store the vaccine, you will likely have to be having your main vaccination. Obviously, there is a different element with that, with care homes and home visits, but that's to do, I think, with the transfer window that you've got, the viability window, which is 2 to 4 hours, depending on which vaccine we are using. Presumably, there'll be SNOMED codes released, and we'll be using our own recall system, or can we keep control? So I assume there's going to be coding that comes through with this in terms of the recall systems. As I said, there's the national or your own local one that you can develop and look at. What have you heard about Ardens are doing? I imagine Ardens are doing loads of stuff. They always are. They're really responsive at helping practices. I don't have any details in terms of what they're currently doing. So more than happy if any of the teams at Ardens want to comment on this, either in the chat or later down the line in terms of what they're up to. But I'm sure they'll be doing loads of stuff to try and help make this process as easy as possible for practices. Christina's mentioned about any difference for ethnic groups. Not as far as I'm aware. There's nothing specific. I'm, again, happy to be proven wrong on this. I think there's different challenges with different ethnic groups, and absolutely there's going to be some elements of, how those cohorts of patients approach the vaccination. Because I know there's been a lot of fake news going on around the COVID vaccination in terms of what it's for and how it works and all the other kind of stuff and things. So I think we are definitely going to have to work harder to support.
Any sign of prioritization of BAME groups in terms of the vaccination rollout?
I'm not sure. So it's not actually specified as far as I can tell from the enhanced service. A lot of it focuses more around age groups and health conditions. So one of the things we didn't show is that there was a slide that listed the priority of the groups that you go for. Absolutely top of the list is the over 85s, and the care home residents is first on the list. Next down, I believe, is over 70s and NHS workforce. And then it goes down to over 65. I can't remember the age criteria and stuff, but much of it seems to be age criteria.
Over 65, high-risk adults under 65, moderate-risk adults under 65, all those 60 years of age or over, all those 55 and over, 50 and over.
Mm-hmm. So there is a prioritization. I've not seen how much of that factors in ethnicity in terms of that. But one of the things we do know is that COVID does seem to disproportionately affect those from an ethnic background. So, I think there needs to be additional work potentially that's looked at how we can support that. And clearly that needs to be from both a practice level and also from a public health and, to be honest, even from a governmental level. We're going to need serious media campaigns to help support this.
It would make sense, wouldn't it? I wonder why people hesitate, and I wonder if it might be something around how it might play into the hands of fake news. For example, you can imagine if there's racial profiling that there might be some sort of fake news around the targeting of that treatment or something.
Absolutely. I remember when we started doing our seasonal flu campaigns, I had patients telling me that's not the COVID vaccine. I heard that they're giving that to people because it kills black people, it kills people of these are the comments that we had. There is a lot of fake news going on around, and it's trying to debunk that. It's trying to make it clear what information we do have. Part of the challenge is we don't know everything. That's just the reality of things. We do not know everything at this stage, and that unfortunately makes the opportunity for fake news to be so much more prolific. It's a real hard challenge, I'm afraid.
It's a shame you might hold back from doing something which makes sense from an evidence perspective because of the fear of it being misconstrued and fake news. Anyway, interesting thought.
I'm just going to rattle through a couple more questions. So we've had a question from John about the difference between an ES and a DES. So we did cover this earlier, John. Feel free to have a look at the earlier part and stuff. I'm not going to be able to have time to go through this in more detail, but it was one of the first things we tackled at the start of this presentation. Can you clarify a person drawing up the vials needs to be the same person to vaccinate? Not sure is the answer to that. I believe that that's what it should be, but there is a mechanism for it to be two different people. But there does need to be two people present when that happens because there needs to be one person to draw up and one person to check. So yes, I believe it should, from an indemnity perspective, I think it has to be the same person. But don't hold me to that. Huge trust issue. What have we got? So Christina mentions that they plan to have a production line to passing it on to the jabber. Cool. Sounds like a good way of doing things. And a few other comments about thank yous and stuff. So loads of questions. I guess, lots of people keep talking about what is the best option for each area. And I think absolutely look at the best option for your practice, look at the best option for your patients and how you're going to approach doing this. Should practice be signing up to the enhanced service? We are not here to tell you that. Absolutely, we're going to be clear on that. The whole point of this webinar is not to tell you what you should and should not do. We've been happy to share what we think we're going to be doing. And again, we've still got 3 more days before we have to have a definitive decision. It again may change depending on what happens. And I definitely see challenges either way. I don't think either one is an easy option. I think both options mean that we're going to be doing a lot more work over the next few weeks and months. We haven't really talked about the £150 million fund, which I know some people may have heard and talked about. I guess one key thing that was explicitly stressed at the webinar was very much that fund money should be used to support general practice through the next few weeks and months. So I've heard, I think many people have heard of some areas where CCGs and stuff have indicated that those funds are going to be used for other things like paying for the COVID vaccination, like paying for secondary care capacity services and all that kind of stuff. One thing was absolutely crystal clear. That fund that for your local area should be used to support general practice because the workload that we are doing is going to change significantly either way. Whether you sign up to the enhanced service or not, whether how that's working, it's going to be different. And yes, there were 7 expectations in terms of what that fund is used for. For example, focusing on learning disability checks, supporting sickness and stuff in the areas, increasing the amount of workforce, both for routine care and stuff and things to try and give some balancing aspects and stuff. But absolutely, that fund is for general practice and to be used to support patient care through functioning general practice. Were you aware of that fund and stuff, Andy?
Yeah, aware of the fund. I think we mentioned it was probably about 2.7 million sort of locally for the Nottinghamshire area. If you break that down on a sort of per patient basis, it's probably less than £1 per patient. So it sounds like a lot of money, but it's not necessarily an enormous amount of money given the scale of the task that we need to undertake. So I think it's just important that it's spent carefully and that it's targeted and it gets to where it's supposed to be. As you've described, I don't really have anything else to add, really.
Yeah, I think we'll find out how it's going to be utilised locally in the next week or two, because obviously the announcement came 6 days ago, in terms of what it actually looked like and stuff. So yeah, I think we've probably covered everything we were hoping to talk about. I know we planned on giving people the opportunity to come and join us, but I think we've been going over an hour now, so I think we've had enough at this point. We hope you all enjoy the session. We're more than happy to try and share further information and stuff in terms of what we're doing and trying to do in our local area. As I said, we're hoping to have some additional content from other providers like System One and other places in the near future to support some of the work many practices are going to be doing with looking at the not only the enhanced service for COVID vaccination, but also in terms of just generally helping you all with general practice and how we're getting on over the next few weeks. It's going to be an interesting time, isn't it, Andy?
It is, yeah. Unprecedented times. So
absolutely.
Yeah, just getting ready to play my part in the biggest, mass vaccination event in history. It will be unprecedented, and I'm sure we're all going to play our part. It's just working out the best way to do that, I think.
So as always, if you do have any comments, questions, feel free to contact us. Definitely leave us a like. Hit the like button. We love it when you do that. Absolutely leave us a comment down below in the chat and stuff, and share this wherever, however, whichever way you want to. As we mentioned earlier, we'll put all the links and stuff to this content in the show notes. That will be on the YouTube platform, or you can listen to it on the podcast, which will the audio version of this will be released in a couple of hours or so, because we just have to regenerate it from there. And as always, EGP Learning is here to help save you and your patients time by taking hands in your primary care and learning. And we will catch you in the next episode.
Okay, take care, guys. Bye-bye.